This talk is about the blink reflex. This test is an electrical evoked event testing the trigeminal facial reflex. It is useful for topographic localization in the brainstem and assessment of brainstem excitability. During this talk, we will only address its use in brainstem topographic localization. The blink reflex consists of technically two studies. One recorded after stimulating a sensory trigeminal nerve on one side, let's say the right side, and the second study after stimulating the other side, in this case the left side. Both studies must be recorded simultaneously and under the same technical conditions because they are interpreted together. This is a normal blink reflex test. The first study consists of stimulating the right side, which is done at the supraorbicularis, infraorbicularis or mental nerves, and recording from electrodes on the right and left orbicularis oculi. With right-sided stimulation, the ipsilateral recording electrode usually captures a biphasic wave. We refer to this wave as response number 1 or R1, followed shortly after by a second polyphasic potential to which we refer to as R2 ipsilateral. R2 ipsilateral has a lower threshold than R1, hence R2 ipsilateral appears at lower stimulus intensity than R1. Whereas on the other side, the left orbicularis oculi electrode after right side stimulation records no R1, but it does record an R2. We refer to this R2 as R2 contralateral to distinguish it from R2 ipsilateral on the side of the stimulus. The second study is performed by stimulating the contralateral trigeminal nerve, in this case the left, while again recording from the left and right orbicularis oculi. The left orbicularis oculi muscle electrode records R1 and R2 ipsilateral with similar characteristics as the ones recorded from the right orbicularis oculi, following right side stimulation, and the right orbicularis oculi electrode only records R2 contralateral. Now we will talk about technical issues. The electronic system used to record blink reflex studies is different from those used for regular nerve conduction studies because it uses special amplifiers with a short blocking time and low internal noise. Yet most blink reflexes tests are performed in a multi-purpose machine by selecting the blink reflex option in the machine. The recording window is usually set at 100 milliseconds with a horizontal sweep speed of 10 milliseconds, a vertical gain usually ranging from 1 millivolt to 100 microvolts. Low frequency filters are set between 3 and 10 Hz, high frequency filters between 3 and 10 kilohertz. The shock should have a duration of 0.1 millisecond. Intensity should be about 2 to 3 times perception threshold. This is usually achieved with currents from 5 to 15 milliamps. In special cases, if with a single 15 milliamps shock no R1 is generated, a pair of shocks of similar intensity, 4 milliseconds apart, often manage to generate R1. We normally collect 3 tracing using 3 stimulus 15 seconds apart from each other. The shocks are timed to fall between spontaneous eye blinks. The 3 tracings can be analyzed separately or interposed. When the 3 tracings are analyzed separately, the best of the 3 is used for labeling. When the recordings are superimposed, the earliest onset latencies are used for labeling, as you can see in this frame. Going back to the stimulus, I have now introduced a cartoon representing an stimulator. The red circle in this talk represents the cathode, the empty circle the anode. The stimulus is supplied under the cathode, either at the supraorbital notch with the anode 2.5 centimeters open laterally, as shown in this frame, at the infraorbital orifice with the anode 2.5 centimeters down, or at the menton orifice with the anode 2.5 centimeters laterally. Surface impedance under the cathode should be of 10 kiloohms or less, and the same on both sides. Now we're going to talk about the recording electrodes. I will use this cartoonish representation of the face to illustrate electrode placement. As you can see, the face is positioned looking to the left, hence we only see the right ear, the right eye unobstructed by the nose, and the left eye partially obstructed by the nose. The searching electrode should be placed in the middle third of the lower eyelid. The reference electrode could be placed at the roof of the nose, forehead, or 1 to 2 centimeters to the lateral side of the eye. The ground electrode should be placed at the chin. The same will be done on the other side as represented here. For the sake of clarity, I will only leave the searching electrodes. We usually instruct the patient to keep the eyes open, but closing the eyes will at times increase the amplitude of the responses. It is wise to let the patient know that they will feel a little pinch with the shocks. I will now bring back the normal study I showed you at the beginning of this talk to highlight R1 and indicate that for the next few minutes we're going to be talking about R1 related anatomy. This is the cartoonish representation of the face I showed you before. On the left side of this frame, I have introduced a right lateral view of the brainstem, and here substituted by a diagram. The region indicated by the arrow is the spine, medulla, pons, and midbrain. Here I'm indicating to the left side, and here to the right side. I have now introduced the right trigeminal ganglion. In it, I have drawn an unipolar neuron and a distal A beta fiber representing the supraorbital nerve. These fibers reach the skin by way of the supraorbital notch. Now, let's go back to the trigeminal ganglion and look at its root, where we can trace the proximal axon of the sensory neuron entering the pontine parenchyma and traveling towards the main sensory trigeminal nucleus. In it, the proximal axon makes contact with the second neuron of this circuit. The neurons in the main sensory nucleus of the trigeminal nerve send their axons towards the motor nucleus of the facial nerve as indicated by the brown arrow. The illustration just added represents a transverse cut through the pons. In it, you can see the motor nucleus of the facial nerve, the salivary nucleus, cranial nerve 6, the nucleus solitarius upper region for taste, and the main sensory nucleus of the trigeminal nerve. So now let's go back to the simple cartoonish representation of the facial nerve nucleus to introduce the neurons innervating the orbicularis oculi. Axons from these neurons in the facial motor nucleus travel through the pontine parenchyma, not as a straight line as I have represented them in this frame, but as you can see here in this new frame, they have a curvy trajectory, which to be better visualized, I will incorporate in the transfer view of the pons. Here is the facial nucleus. Notice that the fibers go back, looking for cranial nerve 6, go around this nucleus, creating the facial colliculus, then forward, passing very close to the taste region of the nucleus solitarius, and advancing in the pontine parenchyma, going down to exit at the level of the pontomedullary cerebellar angle. Now, let's go back to the simple cartoon. As you can see, the fibers from the motor nucleus of the facial nerve form the facial nerve root and advance in the temporal bone, ultimately reaching the stylomastoid orifice. After leaving the stylomastoid orifice, these fibers travel in the facial nerve, reaching the orbicularis oculi. This concludes our review of the anatomy related to R1. After R1, we need to look at R2. So let's start with R2 related anatomy. That is the medullary circuitry of the blink reflex. In this frame, I have introduced a view of the sides of the same face, the right and the left. I have now introduced a segment of the brainstem seen from the back. Notice the inferior colliculi and the fourth cranial nerve. I have now represented both trigeminal root ganglia and the proximal segment of the facial nerve. Now I have substituted the brainstem photograph by an schematic representation of it to introduce the R2 related anatomical system embedded in the brainstem. This system, as we previously mentioned, is called the medullary system, despite the fact that some of its components are in the pons. Initially, I will only represent those anatomical structures involved in the generation of R2 following a stimulation of the right side. In this frame, I have drawn the right supraorbital nerve, which corresponds to the distal neurites of the trigeminal nerve sensory neurons. These axons are A beta and A delta. I have now introduced the facial nerve motor nucleus and the alpha motor fibers innervating the orbicularis oculi on both sides. To introduce the next segment of the medullary system, I want to call your attention to the root of the right trigeminal ganglion. The proximal fibers of the neurons in the trigeminal ganglion travel caudally, forming the spinal tract of the trigeminal nerve. These fibers reach the caudal region of the spinal nucleus of the trigeminal nerve. In this region, these fibers make contact with the second neuron. These neurons send axons to interneurons on both sides of the brainstem. These interneurons then send axons to the respective facial nerve motor nucleus that go on to innervate the orbicularis oculi. These interneurons receive suprasegmental innervation from the basal ganglia and cerebral cortex. These connections render R2 responsive to cerebral influences, unlike R1. I will now incorporate the components of the left medullary circuitry to those from the right medullary circuitry, as you can see in this frame. In this new section, we will put it all together. I will first address normalcy. This diagram combines R1 and R2 related anatomical pathways. I have placed the letter R to indicate the right side and L to indicate the left side of the brainstem. Remember, we are looking at the brainstem posterior surface. The study generated following stimulation of the right supraorbital nerve, indicated by the red thunder, will be represented inside the red rectangle. On the right side of the rectangle, we will represent the activity recorded from the right orbicularis oculi, and on the left side of the rectangle, the activity generated by the left orbicularis oculi. Stimulation of the left supraorbital nerve, represented by the blue thunder, will produce a study that will be represented in the light blue rectangle. Again, the activity of the right orbicularis oculi on the right and the activity of the left orbicularis oculi on the left. It is important to stress that, as you saw in the example of the blink reflex test we used early in this talk, not all labs use the same arrangement to display the results. So after making this clarification, let's see what happens following right-sided stimulation. Upon 3 single stimulations separated by 15 seconds of the right supraorbital nerve, the electrode on the ipsilateral orbicularis oculi will record 3 tracing, one after each stimulus. The machine will select the best of the 3 tracing and label it. The technologist nonetheless has the possibility of changing this selection if chooses to do so. In this case, the top tracing was chosen, so R1 and R2 ipsilateral were labeled on the right and R2 contralateral on the left. The second study is done by stimulating the left supraorbital nerve. I will generate 3 tracing, from which one will be used for labeling, just as we did on the other side. The ipsilateral tracing just generated from the left orbicularis oculi will show an R1 and R2 ipsilateral, and the one generated on the right will only show an R2. The R2 will be called contralateral. Some authors add an asterisk on the side of the stimulus, as I have done in this frame. They do so for the purpose of clarification. Such clarification is important in cases with missing R1. Normally, R1 occurs with an onset latency of 13 milliseconds or less, and less than 1.2 milliseconds later than its counterpart. R2 is considered normal if it meets 3 criteria. The first criteria is having an onset latency of 42 milliseconds or less. The second criteria is that the onset latency be equal to or less than 7 milliseconds of its ipsilateral counterpart. That is, the left R2 ipsilateral is abnormal if the left ipsilateral R2 is 41 milliseconds and the right R2 ipsilateral is 33 milliseconds. And the third criteria is not having an onset latency delay of more than 5 milliseconds of its pair, as you can see in this frame. Pediatric criteria is nebulous. R1 adult values are usually reached by 24 months. R2 adult values are usually reached by 5 to 6 years. Now let's consider abnormal studies. Pathologically, lesions in the blink reflex pathway can be of two types: those that interrupt the current flow, such as those lesions producing neuronal destruction, axonal loss, or conduction block due to severe demyelination, which we will represent by a red burst with a yellow trim. It is important to stress that incomplete nuclear destructions, that is, damage limited to a group of cells within a nucleus, or limited axonal loss that would present as a drop in amplitude of the potentials, cannot be diagnosed using this test, since there is no well-established amplitude criteria for normalcy. The best amplitude criteria for R1 normalcy is more than 0.2 millivolts. The other type of pathology detected by the blink reflex test is conduction slowing due to demyelination, which we will represent by a yellow burst with a red trim. These pathologies tend to occur at 6 anatomical sites of the blink reflex pathway. I will now proceed to enumerate them while indicating their location on the right side. Site number 1. Site number 1 corresponds to the distal segment of the afferent arm of the blink reflex. This segment of the afferent arm stretches from the supraorbital nerve at the supraorbital notch to the pontine region prior to the bifurcation of these fibers destined to travel to either the main or the spinal nuclei of the trigeminal nerve. We will indicate a lesion anywhere in this segment by placing a white burst element at the trigeminal ganglion root, as you can see. The second site is the main sensory nucleus of cranial nerve 5, indicated by a pink burst. The third site is the efferent arm, which includes the facial motor nucleus, interparenchymal fibers, and the facial nerve. A lesion at these sites will be indicated by a yellow burst at the proximal facial nerve region. The fourth site is the spinal tract and or sensory nucleus of cranial nerve 5. This site includes the fibers in the spinal tract of the trigeminal nerve traveling towards the caudal neurons in the spinal nucleus, indicated by the white interrupted line, and the neurons in the spinal nucleus of the trigeminal nerve involved in the blink reflex. This site will be signaled by a green burst in those neurons. The fifth site corresponds to a lesion involving the fibers from the neurons in both spinal nuclei traveling towards the interneurons in the opposite side and sparing their ipsilateral connections, as indicated by the blue burst. And the sixth site corresponds to the tract connecting interneurons and the ipsilateral cranial nerve 7 nucleus, as indicated by the magenta burst. Now we will look at the blink reflex patterns produced by these lesions one site at a time. Two types of pathologies, either producing current interruption or current slowing, can involve the distal afferent arm. In this frame, I have represented a right distal afferent arm current interrupting lesion at the trigeminal root. This pathology will show upon right stimulation no R1, R2 ipsilateral, nor R2 contralateral, whereas left side stimulation will be normal. Lesions producing current slowing will generate upon right supraorbital nerve stimulation a delayed R1, R2 ipsilateral, and R2 contralateral. Left blink study will be normal. So lesions in the distal afferent arm of the blink reflex produce abnormalities on both sides of the face when the lesional side is stimulated. Next, we will look at main nucleus of the trigeminal nerve lesions. These lesions affect neurons, thus interrupt conduction. The current interruption is limited to the pontine circuitry. This interruption manifests by the absence of R1 on the site of the stimulus. Normal R2 ipsilateral and normal R2 contralateral. Left side stimulus generate a normal study. So lesions in the main sensory nucleus of the trigeminal nerve produce an abnormality restricted to the loss of R1 on the site of the lesion when the lesional site is stimulated. Now we will address the third type of lesion, a lesion in the efferent arm. Lesions interrupting current at this site produce an abnormal blink reflex manifested by, upon right-sided stimulation, no R1 or R2 ipsilateral, but a normal R2 contralateral. Upon left-sided stimulation, we find normal R1 and R2 ipsilateral, but absence of R2 contralateral. Lesions localized to the efferent arm producing conduction slowing. Stimulation on the affected side produces delayed R1 and R2 ipsilateral but normal R2 contralateral. Stimulation in the non-lesional side, in this case the left side, generates normal R1 and R2 ipsilateral but an abnormally delayed R2 contralateral. So lesions in the efferent arm of the blink reflex produce abnormalities restricted to the lesional side of the face regardless of the site being stimulated. A spinal tract and or sensory nucleus cranial nerve 5 involvement, if of the current conduction interrupting type, upon stimulation of the affected side will generate a normal R1 but no R2 ipsilateral and no R2 contralateral. Upon non-lesional side stimulation, the study is normal. If the lesion produces conduction slowing, stimulation ipsilateral to the lesion generates a normal R1 but a delay R2 ipsilateral and R2 contralateral. Upon stimulation of the non-lesional side, in this case the left, the study will be normal. So a spinal tract and or sensory nucleus of cranial nerve 5 lesion produce abnormal R2 ipsilateral and R2 contralateral on the lesional side when stimulated. A lesion affecting the bilateral crossing fibers, if of the current interrupting type, upon right-sided stimulation generates normal R1 and R2 ipsilateral, but R2 contralateral will be absent. Upon left-sided stimulation, R1 and R2 ipsilateral will be normal, R2 contralateral absent. Lesions producing conduction slowing, upon right-sided stimulation, we will see normal R1 and R2 ipsilateral, but delay R2 contralateral. Left-sided stimulation will show normal R1 and R2 ipsilateral, but delay R2 contralateral. So bilateral crossing fiber lesions produce abnormal R2 contralateral regardless of the site of the stimulus. Lastly, we will talk about interneuron to facial motor nucleus tract lesion. Such a lesion interrupting conduction at this site will produce, upon stimulation of the lesional side, a normal R1 with no R2 ipsilateral. R2 contralateral will be normal. On stimulation of the non-involved side, in this case the left side, R1 and R2 ipsilateral will be normal, R2 contralateral will be absent. In case of conduction slowing, stimulation of the site of the lesion generates a normal R1, but R2 ipsilateral will be delayed, R2 contralateral will be normal. Left-sided stimulation generates a normal R1 and R2 ipsilateral, but R2 contralateral is delayed. So lesions at the tract from the interneurons to cranial nerve 7 nucleus produces abnormal R2 ipsilateral upon stimulation of the lesional side and abnormal R2 contralateral upon stimulation of the non-lesional side. We have now finished looking at the blink reflex study patterns produced by current interrupting or slowing pathologies at all the sites of the blink reflex pathways. Yet, what is important for us from a clinical perspective is not knowing how to navigate from a known lesion through a maze of possibilities to determine the pattern of blink reflex that is associated with it, but it is all the opposite. It is going from a blink reflex pattern to localization of a lesion. So to conclude this talk, I will show you a flowchart addressing this issue that I have found useful. I like to start the interpretation of the blink reflex test by asking myself if the left R1 is normal. If the answer is no, then I ask myself if the right R1 is normal. If the answer is again no, I am dealing with bilateral disease, likely a peripheral nerve disorder or a neuromuscular disorder. If, on the other hand, the answer to the question is the right R1 normal is yes, then I follow the left abnormal R1 protocol. A left R1 protocol is triggered when the left R1 is abnormal, that is relatively or absolutely delayed or absent. Yet, for the sake of clarity, we will use its absence to illustrate the 3 blink reflex pattern associated with it. In the presence of an abnormal left R1, if the R2 ipsilateral is normal, as illustrated here and enlarged here, the pathology is at the left main trigeminal nucleus. If the left R1 is abnormal, R2 ipsilateral is abnormal, and R2 contralateral is also abnormal, as you can see here, and enlarged here. The pathology is in the distal afferent arm of the blink reflex. If the left R1 is abnormal, R2 ipsilateral is abnormal, but R2 contralateral in the same study is normal, as indicated here and enlarged here. The pathology is in the left efferent arm of the blink reflex. Now, if we go back to the original question in the algorithm, is left R1 normal? And the answer is that it is so. And then you ask yourself if the right R1 is normal. If the answer is no, then I follow the right abnormal R1 protocol, which I will explain in the next few frames. It is important not to forget during the following section that, as concluded, based on the protocol, the left R1 is normal. Hence, the left trigeminal and facial nerves and the left pontine region are normal. So you are left with 3 likely sites of involvement, which we will illustrate as we did previously by using the absence of waves as the criteria for abnormality. If upon inspection of a blink reflex test you find an abnormal R1, ask yourself if R2 ipsilateral is normal or abnormal. If normal, as you can see here, the lesion is in the main sensory nucleus of cranial nerve 5. If R2 ipsilateral is abnormal, then ask yourself if R2 contralateral in the same study is normal or abnormal. If abnormal, as you can see here, the lesion is in the afferent arm of the reflex prior to its bifurcation. When, on the other hand, R2 contralateral is normal in the same study, as you can see here, the lesion is in the efferent arm of the reflex on the side being stimulated. Now, if we go back to the original question in the algorithm, is left R1 normal? And the answer is that it is so. And then you ask yourself if the right R1 is normal, and the answer is that it is so. Then you follow the normal R1 protocol, which I will explain in the next few frames. Since both R1 are normal, you know that the pontine nuclei and their connections and the studied segments of the trigeminal and facial nerve are normal. Then ask yourself about the status of the left R2 ipsilateral. If normal, ask yourself for the status of the right R2 ipsilateral. If normal, judge whether both R2 contralateral are normal or abnormal. If normal, the blink reflex test is normal. If both R2 contralateral are abnormal, as you can see here, the lesion is in the crossing fibers. If, on the other hand, R2 ipsilateral is abnormal, ask yourself if R2 contralateral in the same study is normal or abnormal. If abnormal, as you can see here, the lesion either involves the right spinal tract fibers or the neurons in the caudal spinal nucleus involved in the blink reflex. If, on the other hand, both R1 are normal, the left R2 ipsilateral is normal, right R2 ipsilateral is abnormal, but R2 contralateral in the same study is normal, as shown here. The lesion is in the right ascending tract going from the interneurons to the motor nucleus of the facial nerve. If, on the other hand, if both R1 are normal, but the left R2 ipsilateral is abnormal and the left R2 contralateral is normal, as depicted here, the pathology is at the left ascending tract that communicates the interneurons with the motor nucleus of the facial nerve. But if the left R2 contralateral is abnormal, as depicted here, the lesion is at the left spinal tract and or sensory nucleus of the trigeminal nerve. This approach is summarized in the following algorithm. Notice that the brainstem figure is shown from the front. Please stop the video and take a few minutes to go over it. This concludes our discussion of the blink reflex test. Thank you very much for your attention.